So hi everyone, today we will be discussing about all the classifications from starting to 2026 of the mandibular fractures. I am Dr. Abhin Miglani, Department of Oral and Maxillofacial Surgery. So first of all, we will be discussing what are the different types of angles, or basically we are classifying the different types of angle. So basically, there can be three types into which an angle, mandibular angle, can be divided. So the first of all, we can have the clinical angle. So that's the junction between the alveolar bone and the ramus. So when we open the mouth and look at the third molar, maybe for disimpaction. So the first ridge of mandible close to the third molar when we raise the flap by the Ward's incision is the internal oblique ridge. Then we see the external oblique ridge laterally. So that's the surgical angle. So the surgical angle can be defined as a junction between the body of mandible and ramus. And lastly, the anatomical angle, the most prominent part on the distalmost part of the inferior border of the mandible. When we check extraorally, this is the gonian. So coming to the fracture classification based on the presence of teeth. So this is the oldest classification by Kazanjian and Converse. So it divided the mandibular fractures into three types. So the class 1 had teeth present on both the sides of the fracture line. Then class 2, teeth present only on one side of the fracture line. Class 3, patient is edentulous. Then in 1968, just 9 years after that, Rowe and Kelly gave the classification. First of all, involving the basal bone and not involving the basal bone. So here you can see an easy diagram of mandible showing the alveolar bone, which forms the basis or framework of the different teeth, and the basal bone, which forms the base of the alveolar bone. So if a fracture line is involving till the basal bone, that is, it involves towards the inferior order of the mandible, then it can be classified as the first part of the Rowe and Kelly classification, that is involving the basal bone. Then coming to the Dingman and Natwick classification. So this classification divided again the mandible into in different anatomical parts, like the midline. So the midline fractures were the fractures between the central incisors, parasymphyseal fractures which occur within the area of symphysis bounded by vertical lines distal to the canine teeth. The body from the distal symphysis to a line coinciding with the alveolar border of the masseter muscle, usually including the third molar. Then coming to the angle, the triangular region bounded by the anterior border of the masseter muscle to the posterior superior attachment of the masseter muscle, usually distal to the third molar. Then coming to the ramus, bounded by the superior aspect of the angle to two lines forming an apex at the sigmoid notch. Then the condylar process, area of the condylar process superior to the ramus region. Coronoid process includes the coronoid process of the mandible superior to the ramus region. Then the alveolar process, the region that would normally contain teeth. Then coming to the Kruger and Skilly classification. So it was divided into four parts. The relation to the external environment, whether the fracture line is exposed or not exposed. If it is an exposed, so it can be known as the compound or open. If not exposed to the internal environment, then simple or closed. Even if the fracture line is associated to tooth which has been affected by the fracture line or is periodontally compromised and is linked to the outer surface, it would be known as an open fracture. Then coming to the types of fracture: incomplete, green stick, complete, and comminuted. So then coming to the third, the dentition of the jaw with reference to the use of splints: sufficiently dentulous jaws, edentulous or insufficiently dentulous jaw, primary and mixed dentition. Then coming to the localization, the fracture of the symphysis region between the canine, fracture of the canine region, fractures of the body of the mandible between the canine and angle of the mandible, fractures of the angle of the mandible in the third molar region, fractures of the mandibular ramus between the angle of the mandible and the sigmoid notch, fractures of the coronoid process, and fractures of the condylar process. So here in the diagram you can easily see. Then coming to the AO 2007 classification, which was also known as the FLOSA classification. F stands for the number of fracture segments, L for the location, O for occlusion, soft tissue involvement for S, and A for the associated facial fractures. Then, after 2007, There was another classification which was also known as the modified AO 2007 classification, which was adopted by AO till the year 2014, which just replaced the A of the FLOSA, which was discussed previously, with the I and D. So the I referred to the infection and D refers to the interfragmentary displacement, which can be mild, moderate, or severe. Then coming to the Cornelius classification, which was introduced in the year 2014. So this was adapted by the AOCMF. Then it was parasymphysis was removed and it merged angle and ramus. So here you can see that the midline to canine is the symphysis. There is no parasymphysis, and transition zone is at canine, which is the mesial aspect of canine to distal aspect of semen, that is the body, and there is also a transition zone at 8 from mesial or distal of 8 till the Lakota's line at the angle and ramus fractures. So what is the Lakota's line? So it is an imaginary line which separates the angle, ramus, and coronoid complex from the condylar process. Then coming to the mandibular fracture displacement. So according to the mu- muscle vectors or the muscle pulls, a fracture can be a favorable fracture or an unfavorable fracture. So basically, it is a classification based on the favorability. So if the fracture line plus the muscle pull vector keep the fracture segment buttressed and well reduced, it is known as the favorable fracture. While if the fracture line and the muscle pull vector cause displacement of the fracture segments, it is known as the unfavorable or unstable fracture. Then coming to the horizontally favorable and unfavorable fracture. So this is basically seen from the buccal aspect. So if the fracture line runs from anterior inferior aspect to the posterior superior aspect, so basically from the if the fracture line is running from behind to front, that is from anterior inferior aspect to the posterior superior aspect. And here in the lower border, in the first image, you can appreciate that the inferior border of the mandible has the anterior aspect of the fracture line, while the superior aspect of the mandible has the posterior aspect of the fracture line, which doesn't let the pterygomasseteric sling to pull the fracture segment upwards. Whereas in the horizontally unfavorable fracture, you can easily see that the temporalis, the medial pterygoid masseter muscle, all are involved in pulling the fracture segment upwards. Coming to the vertically favorable and unfavorable fractures, so if we view the mandible in the axial section or from the superior aspect, we can see that the if the mandibular fracture resists medial pull, so it is a vertical favorable fracture. If it doesn't resist the medial pull, and the medial pterygoid causes a posterior superior pull, or the lateral pterygoid causes a medial pull, then it is called a vertically unfavorable fracture. The fracture line in the vertically favorable runs from the posteromedial to anterolateral, while the fracture line in the vertically unfavorable fracture runs from posterolateral to anteromedial. Thank you. Hope you like my video. Please like and subscribe the channel. Thank you.